Welcome, everyone. Thank you so much for joining us today for our webinar on understanding the Physician Services Agreement updates for family physicians. Today, we will explain the PSA in detail, sharing insights on how it affects family physicians in Ontario, and how we can help doctors maximize their revenue potential and opportunities during this time. So let me start by introducing myself. My name is Maral Sanassian, and I am the Director of Client Success at Doctor Care. Doctor Care is the largest provider of billing and practice support for over 2,500 physicians across Canada. On average, we have helped doctors recover $25,000 to $30,000 of revenue per year. We also support approximately 25% of all Faux in Ontario. Our solutions and services are designed to help doctors ensure that they are maximizing their revenue, improving patient care, and growing their practice. Just so you know, all attendees are in listen-only mode. We are recording this webinar, so it will be available to you after the event. If you have any questions during the webinar, please do submit your questions in the Q&A feature. Your questions and your identity will be kept confidential. We will do a Q&A session to answer some of your questions at the end of the webinar. Last month, on March 28th, the Ontario Medical Association and Ontario Ministry of Health announced that a new 3-year Physician Services Agreement had been ratified. As a result, there are several changes that will affect physicians and how they operate their practices. The purpose of today's program is to provide you with an overview of the Physician Services Agreement, highlighting the sections affecting family physicians. We will go through and share what the changes are, how it affects family physicians, and how we can help you. We have broken down this webinar into 9 sections. Here's what we are going to cover today. Faux managed entry, compensation increases, changes to the after-hour requirements, the Faux weekly patient access, virtual care and the codes associated with it, the preventive care bonus, the fee-for-service hard cap, and lastly, updates to billing submissions and reconciliations. Let's start with the first section, which is the Faux managed entry. Here's a summary of the Faux managed entry. Effective April 1st, 2022, the ministry has increased the number of Faux spots available to 40 new Faux spots per month. This amount will increase to 60 by April 2023. There is still a priority for high needs areas. There will be 20 new spots per month available for those practicing in an area with a Rurality Index for Ontario score, which is also known as the RIO score, of 30 or above. For Faux with less than 6 physicians, or those involved in ministry support activities, such as Ontario Health Teams, which is subject to the ministry's discretion. However, the good news is that aside from those 20 spots, there will be another 20 spots open to all family physicians, which will be processed on a first-come, first-served basis. In addition, on April 1st, all new Faux will have to have a minimum of 6 doctors in their group. So for existing Faux, if you have less than 6 physicians, it is highly recommended that you increase your Faux group to 6 by April 2023. However, if for whatever reason you're unable to increase your group size, you will need to make sure that you fulfill the after-hours requirements for groups of 6 and provide written agreement to follow these requirements no later than 12 months following the ratification of the PSA. We do predict that if you are in a well-serviced area with lots of doctors around, like Toronto, that it shouldn't be a problem to increase your group to 6. You can also leverage us to help increase your group size, and we will go into that a little bit later. The ministry will report quarterly to the OMA on the filling of the entry of physicians into the Faux model pursuant to these provisions. For new Faux formations, co-location is required. If all physicians in a group cannot be in the same location, There should be no less than 3 physicians in each location. The distance between the locations must be within a 5-kilometer radius of one another, where the RIO score is 0. For areas with an RIO score greater or equal to 1, there will be consideration given to applications from groups who cannot locate within 5 kilometers due to infrastructure limitations or any other relevant factors. Existing Faux will be allowed to continue as is. However, an existing Faux could not establish a new location more than 5 kilometers away from its existing location. And if a new member is not co-located with the existing Faux members, an explanation will need to be provided to the ministry on their suitability to join. All physicians of new Faux must also have a shared EMR that provides all physicians in the group access to the medical records of enrolled patients. When a Faux group is about to form, the group should be prepared to operate from the shared EMR on the date of commencement. Now, you may be asking, would it be acceptable to have co-locating offices add each other as users to their current EMRs so that patient records can still be accessed and shared without fully being on one shared EMR? The answer is as follows. It is acceptable as long as when a patient goes into any location of the Faux, the physician they see has access to the patient's records, which means the physician can pull up the patient information in that location, even if the patient is enrolled to a physician in a different location. Otherwise, the patient could just go to a walk-in clinic. And speaking of walk-in clinics, let's quickly go over some of the changes that the ministry is looking to implement around walk-in clinics. The OMA and the ministry are working together to develop a framework that will enable and ultimately require walk-in clinics to communicate back to the patient's primary physician with respect to the reason of the visit, as well as the diagnosis and treatment, if any. This applies to both in-person and virtual services. They are also looking to develop a process for communication with patients who regularly use walk-in clinics to understand why they do so and how they could best be encouraged to engage in a continuity of care environment through enrollment with a comprehensive primary care provider, or where they are already enrolled with their own rostered practice. And this again will apply to both in-person and virtual services. So let's go back to Faux groups. In terms of the Faux group roster, effective 3 months after ratification, the average Faux roster size should be no greater than 2,400 patients on average per physician. So the practices of existing Faux with an average roster of greater than 2,400 patients will be reviewed by the ministry representatives. If it is decided that these practices are structured and operating to comply with their contractual obligations, they will be allowed to continue. Any practice which does not comply with those obligations will be provided with an appropriate opportunity to become compliant. So if the practice does not meet the obligations within the time specified or any extension agreed to by the parties, then appropriate steps will be taken to reduce the average roster size per physician to 2,400 or such other larger number as the parties agree to within the time period agreed to. And all of this needs to be in compliance with the CPSO's policies for reducing the patients in a practice. There are also some updates for other models aside from the Faux. So the comprehensive care model and the family health network models are no longer being offered by the ministry. The proposed agreement ensures, though, that existing FINs can continue, and the CCM model will be available as a transitional model for physicians who have applied to become a Faux member. So what do all of these changes mean for physicians? It means that now is a great opportunity for physicians who are currently in a FIG, in a CCM, or even a fee-for-service model to transition to a Faux. Why should you join a Faux, though? Being part of a Faux provides many great benefits. A Faux model allows you to increase your income predictability. On average, 80% of Faux income is guaranteed, regardless of patient visits. You can increase revenue. Faux have more revenue opportunities with additional special premiums and bonuses. You can improve patient access. You get shared on-call coverage for after hours and vacation time. And lastly, it can also help improve patient care because you focus on patient care rather than patient volume. At Doctor Care, we are working with numerous primary care physicians who wish to start a new Faux. And we've also helped hundreds of practices transition from FIG or fee-for-service to a Faux. We can help you understand how a Faux model works and if it's the right fit for you. We can help you add more physicians to your existing Faux group so that you are at the desired number of 6 physicians. We have a promotion that we will share near the end of the webinar that can help you take advantage of this opportunity. If you would like to know and understand more about the Faux model, we have a lot of great videos and resources in the library on our website that you could sift through. Or, of course, feel free to reach out to us if you have any questions. Now, let's move on to compensation increases. On a monthly basis, starting in April of 2022, physicians will receive a payment of 2.01% across the board. This 2.01% reflects the compounded value of the 1% increase in April 2021 and the 1% increase in April 2022. This will continue until March 31st of 2023. The permanent increases resulting from the 2.01% compounded increase in years 1 and 2 will be implemented in the schedule of benefits and for alternate payment plans in accordance with the chart and will take effect on April 1st of 2023. For year 3, the total increase will not be known until mid-2024. So as such, there will be a sequence of lump sum payments that will begin in August of 2024, and then a permanent increase to take effect by April 1st of 2025. In addition to the compensation increases, there is an increase in fee codes effective April 1st, 2022. The ministry did announce that physicians must ensure that their billing software is updated to reflect the new fee schedule code values for the services rendered on or after April 1st, 2022. The updated fee schedule master can be found on the Ministry of Health's website. However, if you do need help updating your EMR with the new schedule of benefits, please feel free to contact us because we can definitely help you with that. Now, let's talk about the changes to the after-hour requirements. Effective July 2022, there will be changes to the after-hours obligations for Faux groups. The screenshot shown on this slide shows a comparison of the number of required shifts for groups with different sizes per week with the new total evening and weekend requirements. Let's talk about the requirements for the after-hour time blocks. If a Faux is required to provide 1 block of weekend coverage, that block will be on Saturday or Sunday. If 2 weekend blocks are required, they may be scheduled anytime on Saturday or Sunday, provided there is no overlap between the blocks. If 3 weekend blocks are required, the Faux may schedule those blocks on Friday evening, Saturday, or Sunday, provided again that there is no overlap between the blocks. Where 4 or more weekend blocks are required, 1 block must be provided on a Saturday and 1 block on Sunday, and any remaining blocks as determined by the Faux, again, provided there is no overlap between the blocks. Each Faux must provide 1 block on each weekday evening, so that is Monday through Thursday, for scheduled and unscheduled visits. To ensure that patients know the after-hours service for their physicians group, those hours should be posted in the office, online, and shared with Ontario Health. In order to support the increased access to scheduled weekend visits, effective 3 months after ratification, so we're looking at July of this summer, 2022, there will be a newly created Q code equivalent in price to the 8888. This code can be built by Faux physicians for providing services to their groups enrolled patients for unscheduled visits on Saturdays, Sundays, and holidays, so long as the physician offers at least 3 scheduled visits for each 3-hour Saturday, Sunday, and holiday block. All family physicians in all primary care models are encouraged to have an online booking system available for their patients. There is no additional financial support for online booking, and please note that this is not a requirement. Family physicians are just encouraged to have an online booking system available for their patients by March 31st of 2023, and to notify Ontario Health of their progress. We highly recommend implementing a system to allow the options for patients to book online to help you and your staff save time, as well as enhance the patient experience. If you do need assistance with online booking, we highly recommend our partners at Ocean. Ocean is the leading provider of EMR, integrated patient engagement solutions. Their platform allows patients and healthcare providers to securely share health information for clinical use, administration, referrals, and research. By adding Ocean services to your existing EMR, the platform allows you to digitally connect patients, primary care specialists, and more. And if you would like to learn more about Ocean, please feel free to send us an email and we would be happy to connect you with their team. So let's move on to the after-hours exemptions. Currently, if fewer than 50% of physicians in a Faux group engage in specific services exempting them from providing after-hours care, the whole group is exempt from providing after-hours clinics. Under the new proposed agreement, this exemption will move from the group level to the individual level. The Faux will be required to provide the total after-hours and weekend coverage for the group based on the group size after removing the exempt physicians. In addition, where there are less than 5 physicians remaining after exemptions are applied, the group will be responsible only for 1 weekday block per remaining physician. So if there is 1 physician only, 1 block is required. If there are 2 physicians, then 2 blocks are required, and so on. If all physicians in the group do have an exemption, then the group will not be required to provide any after-hours care. The physician services agreement has increased the list of exempted services, except coroner services, which are no longer included. It will be up to the group to ensure that the required after-hours blocks are covered. We have listed the exemption services on this slide for you. So we have regular public hospital, emergency room coverage. We've got public hospital anesthesia on-call services on a regular basis, spectacle deliveries outside of regular office hours. We've got regular after-hours care of hospital inpatients, and so on. We're not going to go into detail on the exempted services today, but know that if you do have any questions, please feel free to ask us. Now, on to part 4, our Faux weekly patient access section. There is a new weekly patient access measure effective 3 months after ratification. Faux physicians are encouraged to meet or exceed the following parameters. What are they? 88 face-to-face and virtual patient encounters per week. This, however, is prorated for 1,300 enrolled patients, with at least 60% being in-person visits. The averaging would be measured quarterly for the entire group, and only services rendered to Faux enrolled patients are being measured here. Please note that there is no impact on payment and there are no consequences with this weekly patient access measure. For non-Faux primary care physicians, which include the Family Health Network, the Family Health Group, the Comprehensive Care Model, and so on, they're also encouraged to have 60% or more of their weekly patient encounters on an in-person as opposed to virtual basis. Since this is a group requirement, the average would be measured quarterly over a 3-month period for the entire group. Again, this does not have any impact on your payment and there are no consequences. Now let's move on to virtual care. The virtual care K codes are going away October 1st, 2022. Permanent codes for virtual care services provided by video or phone will come into effect October 1st, which will replace the K codes. Should the necessary changes to the schedule of benefits not be completed by then, the current K codes will be extended until they are. There are some premiums that can be tacked on to virtual visits, with more information to come from the ministry. Virtual visits are in basket, attract outside use, and contribute to the fee-for-service hard cap. Now, where there is an existing patient relationship, which means the rostered patient or the doctor has seen the patient in the last 24 months, the physician will get paid equivalent to the full value for video visits and 85% of the full value of the visit fee for phone visits. If you do not have a relationship with the patient, say you're doing walk-in clinic work, the doctor will receive $20 for the video visits and $15 for the phone visit. Now, for Royal College specialists and GP-focused practice designated physicians who deliver an eligible insured consultation service by video, that video consult will be deemed as initiating an ongoing physician-patient relationship for the following 24 months, just like an in-person visit would. Subsequent virtual visits in the next 24 months, say between the patient and that physician, will be comprehensive virtual services where the video will be paid at par to in-person care and telephone visits at 85%. Here are some virtual care payment parameters that are important to address. So, existing requirements in the schedule, aside from a direct physical encounter with the patient, will apply to virtual care services, including the existing constituent and common elements and the specific elements of providing an insured service. Appropriateness. Virtual care services are not eligible for payment where it is not medically appropriate to provide the services without a direct physical encounter. Where a patient requests a virtual visit and is not willing to present in person, despite the physician's advice and availability, this would be payable using the appropriate fee code for the service that can be completed virtually. However, if before the virtual care service has been completed, the patient agrees to and does present for a direct physical encounter for the same concern, the virtual care service is not eligible for payment, and only the service with a direct physical encounter is eligible for payment. If during the course of a virtual care service, it becomes apparent that the service cannot be appropriately completed without a direct physical encounter, the virtual care service is not eligible for payment, and only the service with a direct physical encounter is eligible for payment. What about verified virtual visit solutions? Video services are not eligible for payment when performed using a non-verified virtual visit solution, i.e. one that is not listed on Ontario Health's public list of their verified solutions. And then last but not least, geographic location. Virtual care services are only insured if the physician and the patient are physically located in Ontario at the time the virtual care service is provided. Moving on to availability. In-person services must be made available by the physician providing comprehensive virtual care services, or by the physician's group within a clinically appropriate timeframe. If it becomes apparent during a virtual care service that an in-person visit is medically necessary, or if at the time of scheduling the service, the patient expresses preference for an in-person visit. Documentation. Virtual care services are not eligible for payment unless the delivery modality is documented on the patient's medical record. Change in modality, the greater part rule. If during the course of a virtual care service, the modality changes, for example, a phone service transitions into a video service, physicians may claim the modality that represents the greater part, so more than 50% of the time spent performing the virtual care service. For time-based services, the combined time of both modalities will represent the total time of the service. Now let's move on to section 6, which is our preventive care bonuses section. Effective April 1st of 2023, the current funding for preventive care bonuses for colorectal cancer, mammography, and pap smears, so basically approximately $32 million, will be used to increase the capitation rate for complex patients as defined by the CIHI grouping methodology. The bonuses paid for influenza and childhood immunizations will remain, but will be prorated for rosters of fewer than 1,000 patients. Therefore, instead of the capitation rate being based solely on the age and sex of the patient, it will be based on the patient's medical comorbidities. For example, the capitation payment for a 50-year-old male with hypertension, diabetes, and coronary artery disease would therefore be higher than the capitation payment for a healthy 50-year-old male. The implementation of these changes will be overseen by the Bilateral Diagnostic Risk-Adjusted Acuity Modifier Advisory Group. This process will take at least a year to complete, so there won't be any changes to preventive care bonuses before April 1st of 2023. Through this process, there will be no decrease in funding to the Faux model. Practices with a mix of patient complexity should not see any change in compensation, but practices with more complex patients would likely experience an increase in compensation. Now onto fee-for-service hard cap. The fee-for-service limits, which are currently at $55,950 a year for individual physician, will also be moved to the individual physician level rather than being pooled in the group effective April 1st of 2023. Those services that count towards the $55,950 cap are not going to change. The Faux fee-for-service limit applies to Faux core services, therefore in-basket services, provided to non-enrolled patients, such as an A007 billed on a non-rostered patient. Services such as emergency department H codes, obstetrical codes, and most inpatient hospital codes do not count. So we've had some questions about what the fee-for-service hard cap is tracking. The fee-for-service hard cap is tracking the in-basket services rendered to non-enrolled patients, regardless of where the services were rendered. So if a physician works at more than one clinic, say at a walk-in clinic or pain management clinic alongside their Faux family practice, any in-basket service rendered to any non-enrolled patient seen will be tracked toward their fee-for-service hard cap. And lastly, let's go through billing submission and reconciliation. Effective April 1st, 2023, claims for services rendered must be submitted within 3 months versus 6 months. However, once submitted, claims will not expire, which means you actually have unlimited time to fix errors so long as the original claim is submitted within 3 months of the date of service. Therefore, physicians will be able to get paid for their services they rendered, even if it takes longer than 6 months to correct the errors. The submission period for remittance advice inquiries, which are also known as RAIs, are extended from 4 months from the date of the remittance advice to 7 months from the date of the remittance advice. Please note that this upcoming 3-month retroactive billing time limit also applies to enrollment and derostering codes. So the Q200, the Q202A, and the Q402A. In summary, there are a lot of changes being made as a result of the physician services agreement that are affecting family physicians. Here are some key takeaways for this webinar for you. Now is a great opportunity to join a Faux model. High needs areas will remain a priority, but half of the spots will be open to all family physicians. As mentioned earlier, there are many great benefits to joining a Faux, such as an increase to your income's predictability and revenue, as well as improvements to patient access and care. We do highly recommend that you consider joining one if you aren't already in one. There will be many compensation increases for the next few years, with the first increase being the monthly lump sum payment for year 2 of 2.01%, compounded value of year 1 and year 2 increases, which you're going to see effective April 1st, 2022. There will be new changes to the after-hour requirements that Faux groups will need to meet. A new weekly patient access measure will be implemented with no impact on payment and no consequences. So as mentioned, the metric is 88 patient encounters per week, which is prorated to 1,300 enrolled patients, with at least 60% being in-person visits. This is recommended, not required. There will be new virtual care codes that will replace the K codes on October 1st of 2022. There are also some premiums that can be added to virtual visits, with more information to come from the ministry. With regard to the preventive care bonuses that we discussed, there will be updates made to take into consideration your patient's comorbidities. The fee-for-service limits are going to move to the individual level rather than being pooled at the Faux group level. Services that are counting currently towards the $55,950 hard cap are not going to change. And lastly, effective April 1st of 2023, claims for services must be submitted within 3 months of the date of service versus 6 months. However, there will be no time limit to fix them once submitted. We know that changes can be overwhelming, and we're here to help and support you. To help keep you on top of all of these numerous updates, we have created a PDF of the PSA summary, highlighting the most important dates affecting family physicians. If you would also like timely updates, we highly suggest that you subscribe to our newsletter. Every month, we share all the latest changes and resources to billing-related subjects, including the physician services agreement. We have entered the links into the chat box, and we will also share these links in a follow-up email after the webinar. Now, this ends the education section of the webinar. Before we move on to our Q&A section, I just wanted to share that we will be extending a special offer to all of our attendees today. So until April 30th, we are offering all attendees a complimentary transition analysis. What does this mean? We will do a free income analysis to show you the value of switching to a Faux model and help guide you through a successful transition. We will explain the Faux model and show you how to increase income predictability and flexibility without disrupting your current practice. In addition, if you are already in an existing Faux group and are looking to add more Faux physicians to get your group to reach the recommended minimum size of 6, we can absolutely help you with that. If you would like to learn more, please contact us at info@drcare.ca and we can help you get started. Now, let's move on to some questions from the attendees in our last couple of minutes. If you have a question that you would like to ask, please submit the question in the Q&A feature in the Zoom console. I will read out your question, but we'll keep your identity confidential. So we'll just give a minute for everyone to have a chance to type in their questions, and then we'll take a look at some of them. Okay, so I see a common theme around co-location. So we've got a question, and basically the question is as follows. So is it acceptable to have 2 physicians practicing in one location and 4 practicing in another location, all within this 5-kilometer radius, instead of the 3 and 3 that is suggested? And so unfortunately, it is not acceptable for new Faux groups to have that set up. So there cannot be less than 3 physicians in any location for new Faux. So in essence, no group is going to be able to form in a location with an RIO score of 0 that has less than 3 physicians in any location at the date of commencement. And also something to be mindful of is that the ministry is developing a reporting system to track physicians that move after commencement and don't actually inform them. And then we've got, along those same lines, a couple of questions with regards to whether they're in the same building but different, same complex, same building, different units. So in essence, if the physicians are located in the same building, and in different units or suites, then for the most part, it is acceptable. It's not optimal, however, it is acceptable if they're in the same building. Okay, so we've got some clarifications around the roster sizes. So will physicians with more than 2,400 patients, in essence, be able to convert from a FIG to a Faux, taking into consideration that many large FIG practices, not all those patients may be active. They may have additional help on hand, such as a locum or an NP. So in essence, no new group will be able to form if the average roster per physician is greater than 2,400. So please note, it is an average across the group. So what the ministry is looking at is the average patient roster across all of the doctors less than 2,400. And then there are some questions around the rostering and re-rostering for transitions from FIG to Faux. So in essence, for FIG doctors that have rosters, if they are provided, if they're basically granted to join the Faux, what happens around the 6-month re-rostering timeline in order to enroll the patient. So the good news is that with the new PSA that was ratified, when a FIG physician moves into a Faux, the roster is going to be transferred over with them. So there is no requirement to re-roster within 6 months, which is something we've been seeing as of late. So luckily that requirement is no longer there. The roster will transition with you from the FIG into the Faux immediately. So that is, in terms of like the re-rostering of patients, that's only still applicable when you are taking over a roster from another doctor. Okay, so I'll take one more question over here, and it's around the after hours services. So the question is, can the after hours block be virtual? So virtual care can be conducted for after hours. However, patients have to have the ability to see a physician in person during after hours if necessary. And this is something, again, that the ministry is looking to monitor from our conversations with them. Okay, so I realize we are right on time. And what we'll do is if we haven't addressed your questions, we will absolutely reach out to you directly after the webinar to answer them. With that, that is the end of our webinar. I want to thank you all on behalf of Doctor Care for joining us today. If you do have any questions, any feedback about the webinar, you are welcome to contact me anytime. We highly encourage everyone to contact us with any questions or concerns at all related to your billing. We are more than happy to help. Our contact information is on the slide. I really hope you have a wonderful day. Thank you.